Good morning. My name is Kevin Infante. Thank you for joining me. Today, I will be presenting a short lecture on a growing public health concern, a disease called non-alcoholic fatty liver disease. This presentation is geared towards adult learners who have some form of collegiate nursing education. Target areas where these nurses work would be critical care, peri-anesthesia, and medical surgical acute floors. Our learning objectives for this session include: after the session, the learner should be able to differentiate between non-alcoholic steatohepatitis, non-alcoholic fatty liver disease, and cirrhosis. Also, they should be able to explain the pathophysiology of NASH. And lastly, they should be able to list the current and future possible treatment options for NASH. At the end of this presentation, there will be an opportunity for a question and answer portion, and there will be a short quiz to evaluate your learning. Let's go over some definitions. Let's define what is non-alcoholic fatty liver disease, or NAFLD. NAFLD comprises of a spectrum of clinical and histopathological changes, including simple steatosis, steatosis with inflammation, steatohepatitis, cirrhosis, and hepatocellular carcinoma. Non-alcoholic steatohepatitis is a more severe form of non-alcoholic fatty liver disease. Here, the fatty liver leads to increased hepatic inflammation that leads to further hepatocyte injury, that then leads to fibrinogenesis and cirrhosis. Liver cell injury leads to cellular ballooning of the hepatocytes, more inflammation, and more fibrous formation of varying severity. This leads to a condition called cirrhosis, which is histological development of regenerative nodules surrounded by fibrous bands in response to chronic liver injury, which leads to portal hypertension and end-stage liver disease. Some background information on NASH and NAFLD. NAFLD is a major cause of chronic liver disease. Global increase in metabolic syndrome, along with obesity, diabetes, and hyperlipidemia, have also led to the increase in NAFLD rates. NAFLD is said to be a manifestation of metabolic syndrome. NAFLD is present in 20 to 40% of the general population in industrialized countries. Of these patients that have NAFLD, 10 to 20% of them have NASH. In European patients with type 2 diabetes, the prevalence of NAFLD is about 40 to 70%. In the US, more than 64 million people are projected to have NAFLD. The annual direct cost of this disease is about $103 billion, or $1,613 per patient. By 2020, NASH is projected to overtake Hep C as the leading cause of liver transplants in the US. NASH cirrhosis is the fastest growing indication for liver transplantation in this country. Let's go over the pathophysiology. A variety of risk factors and mechanisms are associated with NAFLD development and progression. As you can see in this diagram, genetic and non-genetic factors play a role in NAFLD development, as well as metabolic syndrome, insulin resistance, diabetes, obesity, and dyslipidemia. Nutrition plays a role due to the fact that high intake of dietary sugars and saturated fatty acids and cholesterol lead to lipid accumulation in the liver. The liver cells can't handle all these fatty acids, and there is an increase of the toxic lipid metabolites. This in turn leads to hepatic toxicity that lead to activation of death receptors and their ligands, and production of reactive oxygen species. This leads to mitochondrial dysfunction and hepatic injury and death, leading to the picture of NAFLD spectrum. How is NAFLD diagnosed? The diagnostic procedure is called a liver biopsy. Here, histopathologic findings such as hepatic steatosis, ballooning of the hepatocytes, and lobular formation, and perisinusoidal fibrosis would be seen in the tissue biopsy samples. Liver transplantation is the only option for NASH cirrhosis at this time. There is no approved drugs for treating NASH. Bariatric surgery can be done and is an efficient treatment of obesity and causes sustained weight loss with potential reductions in hepatic fat, inflammation, and fibrosis. A type of bariatric surgery is the Roux-en-Y gastric bypass, which is said to be the most effective. Other procedures include sleeve gastrectomy and the adjustable gastric banding procedure. These procedures both reduce gastric volume without altering the upper GI tract anatomy. In the near future, we might be able to see pharmacologic management of NASH in the form of one of these or all of these 5 medications listed here on this slide, which are still on phase 3 stage of clinical trials. If you could recall, phase 3 trials used to compare a new drug to standard of care and assess the side effect of each of these treatments. It is said to hit the market hopefully by 2021. Now we'll go over some questions you have. Okay, someone asked, how many people are waiting for a liver transplant? According to UNOS, there are nearly 17,000 people waiting for a liver transplant in the United States. Next question, how long do patients wait or stay in the waiting list for liver transplants? The median national waiting time back in 2006 was 321 days. Although in my clinical experience, waiting times vary from less than a week to years. Last question, how is a decision made on who gets a liver? The decision on who gets a liver is based on the patient's severity. A lot of patients will have mild symptoms and complications, while some will need ICU admission. A scoring system based on their bilirubin, INR level, and creatinine called the MELD score provides a score based on how urgently that person needs a liver transplant in the next 3 months. The clinical team will decide if this patient is a transplant candidate, if they have the right socioeconomic resources to go forth with a transplant, if they will be able to comply with the lifelong medical and pharmacologic management that a transplant patient needs. The patient is placed on a waiting list, and once a donor organ is available, they are matched to a patient through a computer system that the UNOS uses. However, certain patients will have priority over others. These include pediatric patients and status 1 patients, or patients who have an emergent or severe onset liver failure with a life expectancy of less than a few hours to a few days without immediate transplantation. Thank you for your questions. Now we'll go over a short quiz. Let's go over your answers. For number 1, true or false? NAFLD is a spectrum of diseases that range from simple steatosis to potential liver fibrosis, cirrhosis, and liver cancer. The answer is true. For our next question, blank is an invasive diagnostic test for histopathologic confirmation of NASH and related liver diseases. The answer is liver biopsy. Next question, true or false? Currently, the only treatment option for cirrhosis linked to NASH is liver transplantation. That is true. Next, true or false? The pathogenesis of NAFLD and NASH is complex and multifactorial. True. Last question, blank is a form of NAFLD characterized by liver cell injury, ballooning, inflammation, and fibrosis of varying severity. The answer is A, NASH. This concludes our lecture for this morning. Thank you for joining me today.